This recorded review will be going over Foundations 2, Exam 5 Study Outline, covering chapters 37 through 39. So we're going to start with dressings for wounds with a lot of exudate versus no exudate. So we can find this information on page 784 through 786. We also want to look at the hydrocolloid dressing on page 789. So the dressings here that we'd like to pay attention to are the Tefla dressing on the bottom of 784. It's important to note that a Tefla dressing is good to use for a wound that has an excess of exudate. Another word that we could use is a hydrofiber dressing. So a hydrofiber dressing or a Tefla dressing is great for a wound that has a lot of exudate. Let's also take a look at the type of film or transparent film dressings on page 785. Transparent film dressings like Opsite or Tegaderm allow you to assess the wound without removing the dressing. This is a transparent type of dressing. It's not very bulky, and these are used to cover wounds that would not have a lot of exudate because they do not absorb any type of drainage. So we'd like to use the film dressings for wounds with no exudate. Factors that cause pressure injuries. So for this bullet point, we can look at the factors that affect wound healing on page 778 to page 780. We also want to keep in mind those risk factors for pressure injuries that we discussed for our last assessment. So those are going to be extremely pertinent and may be seen again on this upcoming assessment. When we discuss Merkel cells, we want to recall from our previous structure and function studies that Merkel cells are going to be one of the ones that detect light touch. And Merkel cells are going to be important with our sensation, which is something that we want to consider when we're caring for our wounds on our patients. Patients at a higher risk for developing these pressure injuries, again, you want to pay attention to these factors that affect wound healing on page 778 on to page 780. And again, recall from our previous assessment and the previous chapter, the patients that would be at a higher risk for developing these types of pressure injuries. Treating a wound that requires negative pressure therapy. For this one, we're going to look on page 786. So we would like to pay attention to the guidelines for care of the negative pressure wound therapy dressing, box 38.3 on page 787, as well as, of course, the red safety alert on this page. Now we want to know that the purpose of negative wound pressure therapy, it is a vacuum-assisted closure. It involves applying a suction device to a special wound dressing to institute negative pressure at the wound site, which draws the edges together. So that is what it is and how it works. And that is important to note for our negative pressure wound therapy. Caring for a Penrose drain. So for this one, we're going to look at on page 783, we discussed the Penrose drain under drains and drainage devices. Now notice in figure 38.6 that the Penrose drain has a perforated type of gauze around it. This is how a Penrose drain should look. You want to have a perforated gauze around it. And then you can also read about the Penrose drain on page 783. A Penrose drain is a flat rubber tube. Often a safety pin is placed at the external end of the drain to prevent it from slipping into the wound. Whenever this drain is ordered to be shortened, place a new safety pin proximal to where you cut the tubing to the desired length before cutting the tubing. Catheters of various sizes can be used as drains. So paying attention to that figure that you see there, 38.6, and the text describing the Penrose drain on page 783. Steps for irrigating a wound. We're going to see this in skill 38.2 on page 794. So we just want to understand how you would irrigate the wound. So paying attention to those implementation steps is going to be helpful, as well as, of course, the documentation and any special considerations on 794 to 795. Pre-op interventions to reduce healthcare-associated infections. So for this, we're going to turn to page 37, or I'm sorry, chapter 37. And we are going to For this bullet point, we're going to start on page 757 with skin preparation. So one way that we can prepare to prevent a healthcare-associated infection is by appropriately prepping the skin prior to the surgery. The patient may be asked to shower with a special antibacterial cleanser on the night or morning before surgery, or both, to remove as many microorganisms from the skin as possible. Removing hair from the operative site can be done just before surgery, but it is generally not recommended. Then we can also look on page 766, going on to page 768. And through 771. So for these ones, what we want to look at is under implementation, the different subsections here. For example, protecting the patient from injury. We want to maintain an open airway. This is a priority measure. One of the best positions to place the patient in after surgery is going to be on their side or with their head turned to the side. We do this to prevent aspiration until they are fully recovered, alert, and with their swallowing reflex intact. We want to assess the surgical site when the patient returns to the unit. Make sure that the dressing is dry. If it is not, we can outline the stained area with a pen so that we can further assess bleeding time and look at it again later. Under promoting respiratory function on 767 and 768, we want to make sure to encourage the patient to deep breathe and cough every 2 hours. Coughing could be contraindicated for some patients who have hernia repair, eye, ear, or brain surgery, so always check your surgeon's orders. Some coughing for abdominal surgeries as well can be helped with splinting. So you might want to help the patient understand how to splint their incision prior to coughing, as long as it is okay under the physician's orders. We also want to promote the use of an incentive spirometer. Incentive spirometers are especially helpful to prevent atelectasis and hypoventilation. An older adult patient may need additional coaching to master this technique. We want to also look at the risk of venous thrombosis and potentially use some sequential pneumatic compression devices on the legs or an anticoagulant. These can alternately compress and release, squeezing blood vessels and propelling blood along them. We want to pay attention to urine output after surgery. If the flow is less than 60 milliliters over a 2-hour period, we should be notifying the surgeon. We know that urinary retention can stay in the bladder and encourage a UTI to form. As soon as a patient is conscious and the swallowing reflex has returned, we can offer them a few ice chips or sips of water after we have done an assessment of their ability to swallow, as long as there is an order, unless, of course, there's an order to maintain their NPO status. For promoting GI function, we know that they are not allowed to eat until their bowel sounds have returned after surgery and general anesthesia due to the risk of development of a paralytic ileus. We should listen to their bowel sounds and document them, at least one per shift. Abdominal distension and considerable flatulence are very common after general anesthesia because the GI tract action has ceased. This can cause discomfort and gas pains. One of the best remedies for this is ambulating to help move and evacuate that gas. Also, take only small amounts of liquid or food at a time. Drinking liquids that are neither very hot nor very cold, and refraining from drinking with a straw will help keep gas to a minimum. If permitted, the patient could try resting in a slight Trendelenburg position with the legs and rectum higher than the stomach. This can also assist in the evacuation of gas. Chewing gum, if permitted, will also aid in the return of our proper GI function. Promoting rest and activity, we can have ambulation begin potentially 8 hours post-operatively. Whenever you are preparing to ambulate with your patient, you want to raise the head of the bed first, then let the body adjust to that position change. After you have done that, you may sit the patient on the side of the bed, allowing the legs to dangle over the side with the feet over the side of the bed with their feet on the floor. After a few minutes of dangling, slowly help the patient to stand. Risk factors that contribute to hematoma development. So we kind of discussed this as well when we talked about the venous thrombosis on page 768. And notice how we also mentioned that anticoagulant. So being on an anticoagulant could contribute to the development of hematoma development. Another potential risk factor for bleeding could be the use of alcohol. So alcohol abuse will also lead to potential bleeding. Steps for obtaining an aerobic wound culture. We're going to go to chapter 38 for this. So for obtaining an aerobic wound culture, we're actually going to refer back to chapter 24. You can see this on page 438, going on to page 439. With this specifically, you want to know how you are going to cleanse the wound, around the wound with normal saline, and you also want to pay attention to how you should be using the sterile swab and rotating it to get your sample. Page 438 to 439. Diet for patients with pressure injuries. So for this, we want to take a look at the factors affecting wound healing, which can be seen on page 779 to 780. As well as box 38.1 on page 779, providing appropriate nutrition to optimize blood glucose levels, aiding in the healing process. So an example of a diet that would be appropriate to do that with would be a high-calorie diet. Healing wounds by first intention. So we can see this on page 778. Say a wound with little tissue loss, like a surgical incision, will heal by primary or first intention closure. This is when the edges of the wound will approximate or close together and there is only a slight chance of infection. Alcohol abuse, we already discussed, can contribute to a potential bleeding post-op complication. Informed consent, we're going to go back to chapter 37, and you're going to look under surgical consent on page 753. The surgical consent or informed consent form is a legal form. It must be completed in ink with the correct spelling of procedures to be done. The surgeon is ultimately responsible for obtaining the signed consent. The signature of the patient or responsible party will be witnessed by another party, often a staff member. The consent form should show the procedure to be performed and any risks involved. It should include the time and date and must be signed in ink. A witnessed X is acceptable if a patient cannot sign with a signature, if this is allowed by your institutional policy. If the patient does not understand a procedure, has further questions for the surgeon, you must refer back to the surgeon. If emergency surgery is needed and the patient is not conscious or able to give consent, immediate family should be contacted. Telephone permission could be given as long as there are 2 witnesses on the extension lines. If a family member couldn't be found, the opinion of a second surgeon regarding the need for surgery will be sought, and then the surgery can take place. Smoking tobacco is a risk that could contribute potentially to a deep vein thrombosis type of postoperative complication. So it will increase the risk of blood clots. So when discussing the findings associated with hypervolemia, you want to look on page 768 and 770 under the maintenance of fluid balance. One of the things that we want to recall are the signs and symptoms that you would see with hypervolemia, which would be tachycardia, increased blood pressure, potentially edema, maybe crackles in the lungs. And we can also see a little bit about this in the postoperative assessment within table 37.3. Paying attention to our airway, the circulation, our fluid status, and hydration. Complications of vomiting. We know that one of the complications of vomiting could be potentially dehydration post-op, and they talk about this on page 770. The surgeon will typically write an order for medication in the event of excessive nausea or vomiting. It's best to medicate the patient before the actual vomiting occurs. Postoperative delirium, we can see a little bit about this in the lifespan considerations for the older adult on page 770, noting how fluid and electrolyte shifts could cause confusion in the older adult postoperatively. The older adult will also be prone to shifts in their body fluids, which could lead them to experience orthostatic hypotension when changing to a standing position. So we need to support these patients adequately. Going back to the previous slide, I'd also just like to note that as far as the signs of overhydration or signs of dehydration, we want to look on page 772 within table 37.5. At the bottom of that table, it talks about fluid imbalance and then the signs of overhydration that you would see, as well as signs of dehydration. So as far as manifestations of lidocaine toxicity, there's not a whole lot about it in the chapter here, but an important thing to note about lidocaine toxicity is that if you had it, one of the symptoms you would experience would be numbness around the mouth. Moderate sedation examples. So what this basically means is that you want to identify what type of sedation is used for moderate sedation and then an example of procedures that it would be used for. So on page 752, you can see about procedural or moderate sedation. This is where a patient has a local anesthetic agent given to them at the surgical site, plus IV sedation used to provide systemic analgesia, conscious sedation, and depression of the autonomic nervous system. This technique would be used for any surgery or procedure that would be done with local anesthesia and is being used more and more frequently. The patient will be monitored closely for blood pressure changes, oxygen saturation levels, and local heart activity. And an example of a procedure that this could be used for would be a colonoscopy. Same thing with regional anesthesia on page 752. Regional anesthesia is accomplished by administering a nerve block. This can be accomplished by injecting the spinal, epidural, caudal, or peripheral nerve area. Spinal or epidural blocks are frequently used for high-risk patients undergoing a pelvic or lower extremity surgery, and they are widely used in obstetric procedures. So those would be examples of procedures that you would use regional anesthesia for. Steps for the skin prep preoperatively, we already kind of talked about that one, which is on page 757. Steps to using an incentive spirometer. So we can see that on page 756. It's going to be in the blue patient education box. So using an incentive spirometer is at the bottom of that table there, and you want to pay attention specifically to those bullet points to be able to provide tips and strategies for a patient to use that incentive spirometer. And remember that we said that using an incentive spirometer post-operatively is going to decrease the risk of any post-op respiratory complications, including pneumonia. ABCs. So what we mean for ABCs is that if we're talking about prioritizing a patient and you're given a patient scenario where you need to prioritize what's most important with them, remember to use your ABCs. Airway first, always. Patient-controlled analgesia we can see on page 757. So many surgeons will order a patient-controlled analgesia pump for their patients post-operatively. They should receive instruction about the pump from the nurse and how to operate it before surgery. Explain that this type of medication is ordered on an as-needed basis if they're receiving injections for pain control and that they have to ask for it. It's important to note with the PCA pump, the clinical cues on page 757. So assess the effectiveness of the medication delivered by the PCA pump and notify your surgeon if pain is not being well controlled. Let's also recall from our ethical and legal discussions when we talked about PCA pumps earlier in Foundations 1 that the PCA pump really should only be used by the patient. It should not be pressed by anybody else other than the patient. Splinting postoperatively, we kind of talked about when we discussed the coughing and deep breathing on page 768. So if the patient has had an abdominal surgery, we would want to encourage them to splint their incision while they are coughing, if this is okay with the surgeon and written so in their orders. Caring for a patient with dysphagia. So just basically understand that aspiration is a potential complication of dysphagia, and that's one of the reasons why we want to work to prevent it, as well as assess the gag and swallowing reflex prior to providing any oral intake after surgery. Starting a diet post-operatively and steps for safety. So we kind of talked about that as well. That was going to be on page 771 for promoting gastrointestinal function, as well as 770. So pay attention to the bolded text on 770, and then the assessing for the bowel sounds like we talked about, and of course looking for bowel movements, swallowing, and gag reflex. Complications of dysphagia, we talked about aspiration. Additional tips for dysphagia include using small bites. That's going to be something that we're going to recall from previous discussions regarding assisting patients with feedings. Function of skeletal muscles is going to be in chapter 39. So with this, we just want to understand that the function of our skeletal muscles, that they are voluntary muscles. So again, this is going to kind of recall some of our previous studies from structure and function specifically. So understanding that skeletal muscle is voluntarily controlled. Complications of urinary retention is going to be back in chapter 37, and we kind of talked about that. The importance of making sure that the patient is taking in adequate intake, but also making sure that that patient is releasing that output. So we want to monitor their fluid output to ensure that they are urinating at least 60 milliliters over a 2-hour period. If the patient is unable to empty the bladder spontaneously, you would want to obtain an order for catheterization. And we want to monitor this because we know that anytime that urine sits within the bladder and is retained, it has the potential for developing into a urinary tract infection or a bladder infection. You can also see this on table 39.1 and page 807 with in chapter 39. The stasis of urine is going to lead to potential urinary tract infection. It's one of the complications of immobility as well. With buck skin traction, you're going to find this on page 809 under skin traction. So in skin traction, a Velcro boot or buck traction, belt, halter, or sling can be applied snugly to the skin, and the traction should be attached to the appliant. Note the maximum amount of weight that should be used for skin traction is 10 to 15 pounds. Under the section about traction on 808, it's important to note a couple different things about traction and some different principles of traction with the nursing interventions. You can also very clearly see this within table 39.2, principles of traction with nursing interventions. So we want to make sure that the weights are swinging freely without touching the bed or the floor. The head of the bed should be no higher than 20 degrees to keep the patient from sliding down in bed and keep those weights hanging free. The patient should not be slipping down in the bed, and you should not be allowing the feet to rest on the foot of the bed. Again, we talked about complications of urinary retention, which you can see in table 39.1 on page 807. Using crutches while ambulating. So we can see this on it starts on page 825 and it goes on to page 827. So specifically what we want to focus on for this one is within the patient education box on page 827, focus on the steps that you would want to follow when assisting a patient to walk upstairs with crutches. You can also focus on box 39.5, the guidelines that must be considered when teaching a patient who is crutch walking. So ambulating after surgery, we kind of already talked about that one. That has to do a lot with that sitting the patient up into the Fowler's position. Then we want to have them dangle. Chapter 37. And that's going to be on page 771 under promoting rest and activity. Steps to removing staples from a wound is going to be in chapter 38, and we're going to look at the skill specifically for that one. So you can see this skill on page 798. It's important to focus on the 4 staples part of that and the implementation steps that you would want to use. You can also read a little bit about suture and staple removal on page 797. We talked about the strategies to improve gas pains post-op already. We also talked about the vacuum-assisted wound closure. So again, just understanding with vacuum-assisted wound closure, what the purpose of it is, how does it work, and then paying attention to that box that we had pointed out previously. The purpose of range of motion exercises, so we kind of talked about that one as well already on 39, but you're going to want to focus on you can see it on 806. It talks about circulation and how it's affected by immobilization, how normal movement assists in venous return by the compression of muscles against venous walls when our muscles are in motion, and healthy firm muscles will provide general support for the venous walls. So recall as well with passive range of motion are learning from previous chapters. For example, chapter Chapter 18 when they discuss passive range of motion. You can also see it in the skill about passive range of motion on page 286. And we know that the purpose of passive range of motion is to mobilize the joints and to keep those joints moving appropriately. Healing a wound by secondary intention, we're going to find in chapter 38. And that's going to be on page 778. So a wound with tissue loss, like a pressure injury or severe laceration, will typically heal by secondary intention. In this situation, the edges of the wounds will not approximate, meaning that they do not close together. The wound will therefore often be left open and will fill with scar tissue. CPM machine is back in chapter 39. And you're going to look at the skill for this, which is on page 815. And then you can read a little bit about the continuous passive motion machine on page 814. So we want to understand that this is typically used to exercise an extremity or joint. We know that the nurse is going to have a specific role in the CPM machine as far as setting and regulating it. And that information you will find in the skill on page 815. For transferring a patient using a mechanical lift, we want to focus on page 822, using the mechanical lift to transfer the immobile patient. We know that these lifts can be used to move the immobile patient from the bed to a stretcher, a chair, or a wheelchair, or back again. It's important to understand how you're going to use it. We never want to leave the patient requiring the use of a lift unattended while they are in the lift, tub, or in the whirlpool bath. Explain to the patient exactly what's being performed. And then you can also see that before you place a patient in the sling, you want to be sure that the skin is clean and dry. Protect the sling as needed with a sheet or bath blanket. The proper use of a mechanical lift will allow the nurse to move weak or helpless patients safely while avoiding self-injury. And if you want to refer back to that, you can refer to skill 39.3, which is on 824 for how to use the mechanical lift. So paying attention to the steps in that skill, understanding how to use it. The feeling of an incision just letting go after surgery, that's going to be back in chapter 38. So that's going to be on page 782, talking about dehiscence and evisceration. So understanding the signs and symptoms for dehiscence and evisceration, the risk factors for that those things for occurring, and what you would do if they occurred. And you can see all that in the small section on page 782. On page 781, you can see about the indications of an internal hemorrhage. So internal hemorrhage can be evidenced by swelling or distension in the area of the wound and perhaps sanguineous drainage from a surgical drain. If internal hemorrhage is extensive, hypovolemic shock could occur with a fall in blood pressure, rapid and thready pulse, increased respiratory rate, restlessness, diaphoresis, and cold, clammy skin. You must intervene promptly to prevent a potentially life-threatening situation. Also note that the formation of a hematoma could potentially occur, appearing as a swelling that is bluish red. If a hematoma is large, it can put pressure on a blood vessel and obstruct the blood flow to surrounding tissue. Appropriate sizing of a walker can be seen on page 825. Walkers are adjustable in height. The height is correct if the person's elbow is bent at a 15 to 30 degree angle while they are standing upright and grasping the hand grips. Caring for a spica cast. So in general, you want to just kind of focus on fracture and cast care. That's going to be on page 816 in the blue patient education box. It's also super important to understand the components of a neurovascular assessment. Now, this is performed for every patient who has experienced a fracture, whether they are treated with a cast or with traction. You can read about the parts of the neurovascular assessment on page 815 within box 39.3. And the skin status post-cast removal is going to be included in the cast care as well. But typically that skin is going to be kind of dry and we're going to need to moisturize it. Caring for a JP drain, that question was ended up being removed for this assessment, so don't worry about that one. Normal skeletal traction manifestations, we already kind of talked about that. Just focus on the skeletal traction in regards to Buck's traction on page 809, focusing on the skin traction page. I would also focus on, the skin traction section. I would also focus on the safety alert on page 809 as well. Responsibilities of the circulating nurse, again, that question was removed. Signing the consent form, we already kind of talked about, so just understanding who is ultimately responsible for signing, for making sure that that consent form is signed, and then again, the nurse's role in a consent form, which is in chapter 37 that we talked about. Dangers of immobilization, so that you can refer to table 39.1 on page 807, which goes over the effects and problems of immobility in each specific body system. And we talked about the importance of deep breathing while immobile. You can also see this on page 806. So without adequate physical activity, secretions will collect in the lower airways, leading to congestion and ultimately respiratory illness. Particularly, we're concerned for hypostatic pneumonia or hospital-acquired pneumonia. So indications of dehiscence, we kind of already talked about that one as well and pointed that one out. Why do our elderly patients heal slower? We're going to see this back in chapter 38. And you can see this on page 778 under the factors affecting wound healing with age. So we know that metabolism and regeneration in the chronically ill and older adult will be slower. Peripheral vascular disease will impede blood flow, which can impede healing. Atherosclerosis and atrophy will reduce skin capillaries and impair blood flow to the wound. A decline in immune function will reduce the formation of antibodies and the monocytes necessary for wound healing. We talked about the different strategies to prevent complications after surgery, and we talked about the appropriate urinary output per hour. Indications of abnormal peripheral perfusion, that's going to be looking at that box that we just pointed out in chapter 39 with that neurovascular assessment. And you can also see a little bit about that. Mostly just in that box that we pointed out about the neurovascular assessment, which you can see on page 815. So focusing on that. So those would be indications of abnormal peripheral perfusion. We discussed the hematoma. We talked about sequential compression devices. Who is at risk for our dehydration post-op? Go back to chapter 37. And you can actually see this at the beginning of chapter 37 on page 750. And we know that the infant and the older adult are at the highest risk for any surgical complications due to either immature body systems or a decline in function of their various body systems. Both of these age groups are at a significant risk for dehydration or overhydration. We discussed the maximum amount of weight that can be applied to skin traction, which is going to be 15 pounds. Materials to protect the skin in an immobilized patient. You can see that on so that's mainly going to be under pressure relief devices on page 813. There are a variety of accessories that will aid in the reduction of skin trauma from pressure for patients in standard hospital beds. These could include foam and gel pads, sheepskin pads, and heel and elbow protectors. Pulsating air pads and water mattresses will lie on top of the regular mattress and provide additional pressure relief. And drugs that contribute to delayed wound healing. We can see this on page 780 in chapter 38 under medications. The use of steroids, immunosuppressants, and other anti-inflammatory drugs, anticoagulants such as heparin, and anti-neoplastic drugs will all interfere with the various aspects of the healing process. So just to go back here through the chapters, make sure we got everything. So on page 764, it's important to note that the recovery time in the same-day surgery unit will take about 1 to 4 hours. We talked about maintaining an open airway being a priority measure on page 766. Focusing on protecting the patient from injury, assessing the surgical site, promoting respiratory function, promoting circulation, maintaining fluid balance, promoting GI function, promoting comfort, and promoting rest and activity. Those are all important sections to go over in chapter 37. Looking on in chapter 37 within table 37.5, focusing on those potential post-op complications, looking specifically at wound dehiscence and evisceration, fluid imbalance, hemorrhage and shock, and thrombophlebitis, as well as urinary retention. We discussed that one a few times. For chapter 8, we talked about those different types of dressings. Remember to recall previous discussions about risk factors for pressure injuries, which you can find in chapter 19 that were previously studied. Signs of impending dehiscence and evisceration on page 782. That's about it for 38. And then as far as 39, We talked about how circulation is affected by immobilization on page 806. Effects and problems of immobility within table 39.1 on page 807. Principles of traction on page 808. The principles of traction with nursing interventions, table 39.2 on page 809, focusing specifically on skin and bucks traction on 809, as well as the safety alert on 809. Clinical cues on page 812 will give additional information on how the skin will appear underneath a cast prior to cast removal, preparing the patient for that experience and how they can treat that skin. Continuous passive motion machine on page 814, as well as focusing on the steps and the nurse's role on page 815. Definitely focusing on box 39.3 regarding the neurovascular assessment and different signs of altered perfusion, which is very pertinent for a patient in a cast. Patient education regarding fracture and cast care on page 816, that blue box. Special maneuvers on crutches on page 827 in the patient education box, as well as box 39.5, the guidelines to be considered when teaching crutch walking. The bolded text on page 827, when moving someone into or out of a wheelchair, always be sure that the brakes are set. And that is about it for this study outline. There is one select all that apply question on this assessment, and I wish you the best of luck. Happy studying.